Hello everyone. As a part of epilepsy awareness in the society and in medical fraternity, we will discuss about epilepsy syndrome today, about tuberous sclerosis complex. Previously we discussed about Dravet syndrome. Now today we will discuss on tuberous sclerosis complex. I am Dr. Varadaraja, neurophysician, Nandyal. Recently, I have come across two cases. This is case Vignette 1. A 16 years old adolescent male presented to me with seizures. Age of onset of seizures was 15 years. He is 16 years old. Seizures were started at 15 years. Previously, there were no seizures at all. Seizures were 2 times per month, mainly occurring during sleep. They were GTCS type, and there were no seizures during childhood, and there were no seizures in the family. His development is normal. His scholastic performances are good, going to college. There are cutaneous markers which I am going to show you in the next slides. There is no focal neurological deficit. He is taking levetiracetam 500 milligrams once a day and carbamazepine 200 milligrams once a day. That is inadequate doses of levetiracetam and carbamazepine he is taking. This is the photograph of the patient. One photograph showing face and another over back of the trunk. Over the face there are many fibroangiomas known as adenoma sebaceum, and over the back of the trunk there is hypomelanotic macule, usually called as ash leaf macules, and there are other patches over the trunk on this patient, shagreen patches. And then these are the neurocutaneous markers we found on this patient. Workup done for this patient was EEG, which was normal. MRI showed subependymal nodules, cortical and subcortical tubers, and white matter heterotopia. Ultrasound was normal. There were no angiolipomas. Fundus was showing retinal hematomas. These were the MR images of this patient. There are subependymal nodules, cortical tubers, and white matter heterotopia. So diagnosis is straightforward because of neurocutaneous markers in this patient. That is tuberous sclerosis complex. So there is a clinical diagnostic criteria for tuberous sclerosis complex with major and minor criteria, which is fitting in this patient. Major criteria includes skin involvement with hypomelanotic macules more than 3 with at least 5 millimeters in diameter, angiofibromas at least 3 or more than 3, or fibrous cephalic plaques, inguinal fibromas more than 2 in number, 2 or more than 2 in number, shagreen patch, multiple retinal hematomas, multiple cortical tubers, and or radial migration lines, subependymal nodules at least 2 or more than 2, subependymal giant cell astrocytoma, cardiac rhabdomyoma, lymphangioliomyomatosis, and angiomyolipomas, 2 or more than 2. These are major criteria. And minor criteria, few skin lesions with 1 to 2 millimeter in diameter, dental enamel pits, intraoral fibromas, retinal achromatic patch, multiple retinal cysts, non-renal hematomas, and sclerotic bone lesions. Presence of two major criteria is sufficient to make the diagnosis of tuberous sclerosis. In this patient, almost 6 major criteria are there. If only one major criteria is there, patient should have at least two minor criteria. So clinically, this patient fits into tuberous sclerosis. Usually, for confirmation, genetic testing is not required if patient fits clinical criteria, but it is helpful to define the disease status, whether it is caused by tuberous sclerosis 1 gene mutation or tuberous sclerosis 2 gene mutation, and to assess reproductive risks for relatives and to define possible tuberous sclerosis complex. The purpose of presentation is, in this patient, usually tuberous sclerosis is characterized by oak triad, which consists of epilepsy, low intelligence, and adenoma sebaceum. But epilepsy, the peculiar feature in this patient, there were no infantile spasms, which was the characteristic feature of tuberous sclerosis, and seizures also late onset, adolescent onset in this patient. His development was normal. There was no mental retardation. There was no positive family history in this patient. That's why I presented this case. Case vignette 2, again this is also an adolescent boy, 15 years old male, presented with seizures 2 episodes on the same day and February 2nd, 24. But there were similar complaints at the age of 3 years. In between there were no seizures. He has low IQ with poor scholastic performances. Even though he is 15, he is still now in 6th standard. There are behavioral problems with increased anger and repeatedly telling same words each time. So this patient had epilepsy, this patient had low intelligence, this patient had behavioral abnormalities, and if we look at his face, there is adenoma sebaceum or facial fibroangiomas. So this patient fits into oak triad. These are the MR images of this patient showing subependymal nodules, cortical tubers, and radial migration lines or radial bands. So oak triad is remembered by a mnemonic epiloia. Epi means epilepsy, low, low means low intelligence, A means adenoma sebaceum. This patient fits into oak triad. But this oak triad is present in less than 1/3 of patients with tuberous sclerosis complex. Coming to epilepsy in tuberous sclerosis, almost 75 to 90% of patients will have epilepsy, but epilepsy is not a major or minor criteria in clinical diagnostic criteria of tuberous sclerosis patients. Usually they begin in the first year of life in the form of infantile spasms. If there are no seizures in the childhood, still they remain at risk for new onset seizures into adult life. We can predict the epilepsy in tuberous sclerosis patients with the presence of tumors on MRI, that is cortical glioneural hematomas with the central low signal on FLAIR MR images, positive genetic testing for TSC2 variants, tuberous sclerosis 2 gene variants. Seizure semiology, they are infantile spasms, most common at initial diagnosis. Up to 25% of children with infantile spasms may develop tuberous sclerosis in the future. Other seizure types are usually focal in nature, focal onset seizures with or without impaired awareness, focal onset seizures with bilateral spread, subclinical seizures. Generalized tonic-clonic seizures are less common in tuberous sclerosis patients. See, surprisingly, despite the high frequency of seizures in tuberous sclerosis patients, epilepsy is not one of the diagnostic criteria in clinical criteria. EEG abnormalities are seen in 75% of patients. They are in the form of mainly focal or multifocal discharges, hips arrhythmias in 19%, and generalized spike and wave abnormalities in 8% of patients. The complications we expect in tuberous sclerosis patients are in the future. They may develop subependymal giant cell tumors from subependymal nodules. Because of subependymal nodules, they are present at ventricles in the subependymal region. Sometimes they may cause obstructive hydrocephalus. Cortical tubers is responsible for refractory seizures, and these patients have behavioral problems which are difficult to manage. These are the neurological complications of tuberous sclerosis patients. Then renal complications, hypertension, refractory hypertension, chronic kidney diseases, and renal cell carcinomas, and respiratory complications like pneumothorax, and muscular complications like rhabdomyosarcoma. So we have to follow these patients. Once they are diagnosed as tuberous sclerosis, we have to follow them. We have to monitor for these complications and treat accordingly. Management of epilepsy. Epilepsy in tuberous sclerosis is difficult to manage. The drugs we can try are vigabatrin for infantile spasms. It can also be tried without infantile spasms with focal seizures. ACTH, adrenocorticotropic hormone for infantile spasms. For focal seizures, brivaracetam, carbamazepine or oxcarbazepine can be tried. For refractory epilepsies, these are the drugs and some surgery available. These are the recent updates. Everolimus is a mTOR inhibitor. mTOR pathway dysregulation is the main culprit for the development of benign tumors in tuberous sclerosis because of gene mutations in TS1 and TS2. TS1 gene mutation variant phenotype have benign course, whereas TS2 gene mutation variant phenotype has vivid course. Other drugs we can try are cannabidiol, and in refractory cases ketogenic diet, vagus nerve stimulation. Recently, this is in research state, epilepsy surgery, that is magnetic resonance guided laser interstitial thermal therapy for resecting cortical tumors which are responsible for refractory epilepsy. For brain tumors, everolimus, which is an anti-neoplastic actually, pharmacologically we can try it with everolimus, and another option is surgical resection of subependymal giant cell tumors. These are the some of other neurocutaneous markers which clinches the diagnosis and which always help us to look into neurological issues if there are these skin markers. One is K-flat spots, neurofibromas and Lisch nodules in iris. They points towards neurofibromatosis type 1. Portweinstein points to Sturge-Weber syndrome, and ataxia telangiectasia in the eye towards ataxia telangiectasia. These are the some neurocutaneous markers. So If a patient presents with seizure, always try to look for any neurocutaneous markers are there, so that we can define a epilepsy syndrome in these patients, so that appropriate treatment can be taken. Thank you.